Just as a reminder, next week's speaker will be Dr. James Leggett, and he'll be speaking on antibiotic pearls. Today we're really lucky to have a multidisciplinary approach to our talk, a very important topic of falls in the elderly. And we're joined by two speakers, Dr. Lisa Miura. She's Assistant Professor of Medicine at OHSU and the Medical Director of the VA World Collaborative Dementia Program. She earned her medical degree from University of Pennsylvania, then did her residency at OHSU and later a geriatrics fellowship at UCLA. Dr. Miura's experience working both as a geriatrics hospitalist as well as a primary care physician. She has published her work and research on falls and also runs the Portland VA Geriatric Assessment Clinic and the Fall Assessment Clinic. And she's joined today by Ron Blehm, who's a former CAL FIRE firefighter and EMT, who's now been practicing physical therapy for 27 years. Ron is an American Physical Therapy Association certified exercise expert for aging adults, as well as an American Sports and Fitness certified senior fitness instructor. Ron's participated in several research studies, including in the areas of Gulf War syndrome, chronic pain, Parkinson's, and falls. And in addition to his research, does clinical work in the Parkinson's, geriatrics, and weight loss programs. So really glad of their expertise and both of their viewpoints to share with us today.
Okay. All right, thank you, Laura. So we're really excited to be here today to talk about a topic that we're very passionate about. And we also want to thank Dr. Marion Hodges for suggesting us in the first place. We actually gave this talk at Portland Providence last summer. And if you heard it back then, we've made some changes, and we even added audience participation questions. So hopefully you all have your clickers, and we'll go ahead and get started. So we have a lot to cover today. We're going to start with an overview of falls with the cost and causes. And then we hope that you'll feel comfortable after this talk with how to perform a falls risk assessment, as well as gait, balance, and mobility assessments. And Ron will review those in detail. We hope you'll learn about fall prevention interventions for your practice. And we'll briefly review inpatient falls and management. That's one of the new things we added. And then finally, we're going to describe our Portland VA Fall Assessment Clinic. So I like to start with a definition of a fall. And this definition is from Dr. Mary Tonetti. She's a geriatrician at Yale, and she's published extensively on falls. And she defines a fall as anyone inadvertently coming to rest on the ground or lower level. So this can be a piece of furniture like a bed or chair. And the falls literature tends to exclude falls related to trauma or what they call an overwhelming medical event like seizure, syncope, or stroke. It's important to know that falls are not random events. So they tend to be an interplay of three different things. One being patient characteristics, two being the activity at the time of a fall, and then three, something in the environment. So if you have your clickers ready, we'd like you to choose an answer. Which of the following is true? A, community fall rates are in the 50 to 60% range. B, falls are more common in the home compared to nursing facilities. C, fear of falling is not a strong risk factor for falls. Or D, fall injury hospitalizations cost more than all other injuries combined. I'll give you a few seconds there. Okay. So Ron, do I? Only one is true? Oh, sorry, only one is true. Yes. Yeah. Okay, let's give you a little more time.
There's more than 14 people here.
Yeah. Oh.
A is at the top, D is at the bottom, not the very bottom.
Oh, it's hard to see on the clicker. Okay.
There we go.
Okay, we only have 19 people, 20. Okay. We'll wait for a few more.
You don't see a blue dot.
Oh, yeah, you need to turn it on. Yeah.
It's anonymous, don't worry.
Okay, we're only in the 20s. There's more people here. Okay. I guess we're...
See, there's a couple more clickers going around here.
Yeah, okay. Okay, some are being passed out. Okay, all right, that's good enough. We're going to stop at 25.
Hit display.
Okay. Yeah. There we go. Okay, so we have, yeah, all right, kind of a range there. So the correct answer is D, and we'll review the others. Okay, let's hide this.
Yep.
Okay.
Which was the correct answer?
Oh, D?
D.
Yes, D is correct. And we'll talk about that. If I could advance this. Ron,
Oh,
this
we
is
might
not
have
advancing.
No, we might have to click over here. Yeah. Now it should go.
Okay. So we're going to talk about the cost of falls. So each year, 30 to 40% of folks over the age of 65 and 50% in long-term care will experience a fall. So that was letter A in that question, where I had 50 to 60% fall over age 65. And then this was letter D, so this was the correct answer, that fall injury hospitalizations cost more than all other injuries combined. And fatal falls account for 179 million, non-fatal falls 19 billion. So very expensive. Complications leading are the leading cause of death from injury in folks over age 65. And we see with falls in general that about 10 to 15% have a serious complication like hip fracture, subdural hematoma, and the like. Other costs that are factored into these numbers are follow-up care, rehabilitation, medications, and also caregiver burden. And some numbers for Oregon, there are about 400 deaths and 86 hospitalizations related to falls. So reducing falls is a very important CMS objective as well as public health concern. A little bit on the sequelae of falls. There's a lot of data to show that falls are associated with worse outcomes. So a decline in functional status, increase in nursing home placement, and also increased use of medical services. How many here have heard of the term the long lie? Not many, it looks like. So in the falls literature, they talk about this as being that half of those who fall are unable to get up without help. And sometimes they're on the ground for an hour or more. And the problems with that is that you can have rhabdo, dehydration, acute kidney injury, and pressure ulcers. I'm sure some of you have seen those unfortunate results. The long lie also predicts a lasting decline in functional status. There's another term that I'd like you to be familiar with called the fear of falling. How many have heard of that? Okay, so more have heard of that term. So fear of falling is actually a risk factor for a fall. And it's also known as post-fall anxiety syndrome. And about a quarter of fallers will limit their activities due to this fear of falling. We see it in about 50% of post-hip fracture patients. And the literature shows that these folks are at increased risk for institutionalization as well as excess mortality. So the bottom line is that falls in the elderly are unfortunately common, associated with a high morbidity and mortality. There are many causes and risk factors that we'll talk about, and falls are potentially preventable. I wanted to say a word about prevention because there are studies to show that education and activity programs can reduce fear of falling as well as improving measures of stability and strength. Risk factor interventions can also be effective. So why don't we always address falls in clinical practice? I was in primary care for a number of years, and I can really relate to how difficult that could be in a short appointment, especially since falls can be pretty complicated, so they tend to be multifactorial. The other big factor is that oftentimes the provider or patient mistakenly believes that falls are just an inevitable part of aging. And so there's just this lack of an awareness of how important falls can be. And then lack of an awareness of evidence-based interventions can sometimes be an issue, hopefully not after today's talk. And then the last one are logistical barriers. And we've found that actually in our fall assessment clinic at the Portland VA, that a lot of times we'll make recommendations, for exercise or Tai Chi, but due to finances or lack of transportation, the patient isn't able to carry out the recommendations. So when it comes to cause of falls, usually multiple causes are involved. Falls are the prototypical geriatric syndrome in the sense that oftentimes it's not just one thing, and we'll go through causes next. Oftentimes falls are unwitnessed, and there can be a very poor recall of the event. And there are different ways to categorize a cause that we'll talk about. So in this particular study for the etiology of falls, the top two I highlighted here. So accident and environment would be number one, and then number two, a gait or balance disorder. So this slide talks about various contributors to falls as we age. And what we find is that it's oftentimes a complex interplay of chronic disease as well as other impairments. So one of the things we see, especially over the age of 75, are gait changes, where the feet aren't picked up as high. There are slower, shorter steps. Decreased strength can also be a part of this, and then this results in a broader-based, more cautious gait. Postural instability can also be an issue, so problems with position changes, and that can be related to slowed processing, decrease in proprioception, and altered balance strategies. And then the last thing to think about would be sensory and cognitive impairments. So vision and hearing issues can be contributing, as well as memory problems. And what we find is in patients with dementia, they are 8 times more likely to fall than their counterparts without dementia. So this slide shows a study looking at 16 multivariate studies. There are a lot of risk factors out there, over 20 when you look at the literature. And I highlighted the top 4 here to think about. So muscle weakness, prior fall, balance deficit, and gait deficit. And these risk factors tend to work in an exponential fashion, meaning the more that you have, the higher risk your fall risk will be. So for instance, in one study, it showed that 27% of those with 0 to 1 risk factors had a fall versus 78% if you have greater than 4 risk factors. So I'm going to talk a little bit about screening. So there's evidence to show that screening is helpful. The USPSTF recommends screening at age 65. And this is to identify older adults who are at increased risk for falls. Being folks with a history of falls, mobility problems, or poor performance on the timed up and go, also known as the TUG. Other specialty societies, such as American and British Geriatric Societies and the American Academy of Orthopedic Surgeons, recommend screening also at age 65. And the number needed to screen to prevent 1 fall over 1 year is 20, which is a pretty impressive number. So worthwhile to screen. And screening questions are pretty basic. So these are the 2 main ones that we typically ask. So number 1, have you fallen in the past year? And if so, how many times and under what circumstances? The second question is, have you experienced difficulties with walking or balance? So if the answer is yes to either one of these questions, then you would proceed with a falls risk assessment. So what is a falls risk assessment? This is where you determine this multifactorial fall risk. And we kind of use this as a checklist of things to go through. So you ask about a history of falls, and then assess the gait, balance, and mobility. Ron will talk about that next. And then on your exam, look for any neurologic impairment, muscle weakness, cognitive impairment, check visual acuity, and then also find out about cardiovascular risks, such as arrhythmias. Orthostatic hypotension is something important to assess for. And then look at the feet, check out the medications, and then finally talk about environmental hazards. Okay, I will pass this on to Ron.
I am going to guess that we need to clear out the first guessers next. Don't want that one. Oh, let's do that. Okay. See if that works. Okay. So I'm going to start this up. Get out your magic clickers, and here we go. So the tug is the timed up and go. We just talked about that as one of the screening things that might be key in finding those that are at falls risk. The TNETI, or the Performance-Oriented Mobility Assessment, and the Berg Balance Scale. We're going to talk about each of these as we go through my part here. Combinations of the timed up and go with gait speed, or timed up and go sit to stand, or gait speed and the infamous Romberg. So we had 25 last time. We should at least get 25 this time around. I know this isn't really your specialty. That's why you refer to guys like me, right? All right, 25. Good. Let's see what we got here. Display. Oh, it's not. There we go. All right. Good. Good. So most people went for C, which I believe we will find out is the correct answer. So yeah, and then the other one is timed up and go and gait speed. Nice. Very well done. Let me clear this out before we move on. Okay. Hide. And, okay. So that was like your pre-post test thing. We're going to talk about each of these kind of in a little bit of detail. I put the TNETI and the Berg and the BEST. Anybody heard of the BEST test? So that'll be new for you guys. So I put those kind of together because I'm just going to breeze over those. And then the next four we're going to see showing up several times throughout the rest of the talk here, because those are kind of like four pillars of falls risk assessment, even though they're probably less common or less well known. So the TNETI, the gait and balance test, now commonly known as the POMA. I brought in a copy if anybody wants to look at it afterwards. It's 2 pages, one section on balance and one section on gait, and then you score them together. What does this say? The assessment takes 10 to 15 minutes. Dr. Miura talked earlier about primary care setting and how pressed you are for time. And to spend 10 or 15 minutes going through this can be a little arduous for some. There's also the Berg Balance Scale. That's more of a static balance. I also brought in a Berg for you. That's like 3 pages to go through. And this says it should take about 10 or 15 minutes. 15 to 20 minutes, a little longer for the Berg. But they look at several different components of balance and mobility, including sit to stand and transfers. The BEST test, primarily focused on Parkinson's, which is maybe why you guys haven't heard that as much. What's nice about it is it groups the tests into 6 main systems: stability versus posture versus gait. And it tests components of each of those. So by identifying the disordered systems, therapists can better utilize specific types of treatments. Very thorough, but speaking of time, I mean, this takes me 40 minutes to do. There's a mini BEST that I can do in 20, and they're working on validating a micro BEST. And by the time you do that, you've done some of these others. So one of the ones that we do in our fall assessment clinic is the 4-stage balance test. We end up down here with a Romberg anyway, and a single limb stand. So some of these other things, like the Berg, have single limb stance and heel toe. This includes those. So we start easy and go more difficult, more advanced, more advanced. It says 10 seconds. I usually make patients go 12. Norms for patients 75 and older on single limb stance is 12 seconds. So I usually have them go 12 seconds on these. But still, 4 times 12, I mean, you're less than a minute, and you've done this test. The reference is steady, and we're going to talk about that at the end. So hang in there. Timed up and go. Anybody do this in your clinic on a semi-regular basis? That is excellent. So timed up and go, or timed up and go and a return kind of thing. You time the patient from getting out of the chair, walking 10 feet around the cone. So it looks at their ability to arise and their initiation of gait and their cornering and their sitting back down. Again, if it's more than 14 seconds, that indicates a falls risk. Greater than 20 seconds, and those guys are very, very unsafe and require further evaluation. Again, if you're going to do the 4-stage and the timed up and go, so you're about 90 seconds into evaluation, and you've done 2 really critical tests. 10 feet one way around the cone, 10 feet back. Yeah, so it's 20 feet, really. Yeah. So where we do our assessments, we have to open the door. So then that's 2. You get 5 feet through a door, another 5 feet, then around the cone kind of thing. So you get the doorway thing in there, too. And then additionally, if you add a cognitive or physical task, that increases the difficulty. So just yesterday in clinic, we had a guy, the doc thought he was a falls risk. He was referred to one of our other therapists. They did the Berg and the dynamic gait index, and the guy scored 100%. So yesterday we did the timed up and go. He was under 14 seconds. That was good. Then we had him do a cognitive task of naming F words, only the nice ones, while walking and going around the cone. So first of all, he could not name any F words while walking. 2, it took him 37% longer to do the tug when he was doing a cognitive task. This guy scored 100% on the Berg and is a significant falls risk. So then again, we have a 20-second exam. Super effective for finding even those that are otherwise pretty well compensated.
Walk and think at the same time.
Walk and think at the same time. And then if you do something like walk and talk and text, then your mortality goes up, right? 30-second sit to stand, one of my all-time favorite ones, because some of the geriatric literature recommends a 5-time sit to stand, and if the guy is weak, he can only do 5 in 30 seconds anyway. But it's an endurance test. If a guy is cranking out 15 or 20 reps, that's endurance for the quads, which tells me a lot about his functional status in life. So it's pretty easy. Just record the number of times up and down in 30 seconds. There are norms published all the way down to the age of 30. This is a geriatric talk, so we cut it off at 60. I was tempted to have you guys do this here right now, but with the seats that flip up and down, it's kind of hard, and then you'd be a falls risk, so let's not do that. And gait speed. I also love gait speed. I don't care if a guy is coming to see me for a hangnail. I check gait speed on everybody, just because there's so many things. Functional ability, balance confidence. We talked about the fear of falling and the risk factors associated with that. Functional decline over time. If I saw a guy in 2009 and I did a gait speed and I see him now and his gait speed has deteriorated 25%, even if he's here for a rotator cuff, that's a worrisome thing. So I check that on everybody. So basically what you do, and you talk about not having 10 feet in your treatment room. Now we're talking 10 meters. But in my clinic, it's convenient because I have the waiting room, and then there's a doorway, and then it's 10 meters to my treatment room. So it's perfect. I can check it on everybody. But basically, you have an acceleration time, and you time that 10-meter stretch, and then you calculate their speed in meters per second, which 10 meters, 10 seconds is pretty easy math. Several references again here: functional ability, balance confidence, hospitalization, and mortality risks. So 1 meter per second, that's kind of the graduating, that's 100%. Okay, you can pass with 80% or 65%, but then we're getting into these guys that are kind of dodgy down there. But it's easy to do, and it's very well documented that gait speed is a significant sign of those who might be at falls risk. There are norms, and again, notice even the very aged are above 1.0 meter per second. At our hospital, if somebody comes in with a stroke or an amputation, the acute care or rehab team performs a FIM, Functional Independence Measure, which is assessment of their independence in doing things like getting dressed and going to the toilet and feeding themselves and combing their hair and walking across the room. Gait speed predicts post-hospital discharge 78% of the time, period. And it did not strengthen it by adding the FIM, which takes like an hour and 6 people. So a little talk here about our assessments that we do.
Okay. All right, so back to the falls risk assessment. I would encourage you to consider a systematic method for your clinical assessment of these folks. And what we would recommend is a targeted H&P and focusing on, and I starred the two strongest predictors of a fall being a history of a previous fall as well as lower extremity weakness. The other things to look for would be a neuro exam and include some sort of cognitive test, such as the 30-point MoCA or SLUMS or even the MMSC. We don't recommend that as much because it's copyrighted. We like to do the mini-cog, which is just the registration of 3 items, the clock draw, and then the recall. It takes about 5 minutes or less, so that would be a consideration. Cardiac exam is important, including orthostatics. Examine the feet and footwear, and then check for vision and hearing, or just consider referring to examine those further. So managing the chronic medical issues can also be key. I listed the ones here that we most commonly see related to falls, being osteoarthritis, stroke, diabetes, Parkinson's, chronic pain, and cognitive impairment. And then the last thing to think about is to ask about alcohol intake. So problem drinking is associated with falls, and we actually see that quite a bit in the population that we take care of. Okay. Question number 3. So what is the highest risk medication for falls? A, tamsulosin, B, olanzapine, C, MS-Contin, D, melatonin, or E, omeprazole. So those of you with clickers, if you wouldn't mind voting. Okay. And there is one answer that is most correct. Okay, wait for a few more. Sorry, I hit display when it's done.
Stop. And
Stop,
then
okay.
Yeah.
Okay, a few more. Anyone? Okay, we'll stop at 22. Okay, there it is. All right, interesting. Okay, so the most answers for C, MS-Contin. I'll show you some data about the opiates, or we'll talk about that. The answer is actually B, olanzapine. Okay. All right.
Continue or
yeah. But I should hide this. Okay, so this slide is based on a meta-analysis of 22 studies. This was published in 2009. What was interesting about this study is that the opiates were not considered one of the higher risk medications. And the top 2 were psychoactive medications, especially antipsychotics, the anti-anxiety drugs like benzos, hypnotics, and antidepressants, and that's both SSRIs and the tricyclic antidepressants. So those are the ones that you think about first. And then the cardiovascular were also high, such as the antihypertensives, especially vasodilators that can cause orthostasis, and diuretics. When it comes to medications, it's not only the specific classes, but also the number. So what number do you consider polypharmacy? It's not very high. Yes, so over 4 would be considered polypharmacy. And that's basically all of our patients that we see are on at least 4 or more medications. So that's very common. The other factor is a medication new, or has there been a dose increase? So those are things to think about when it comes to falls. Okay. I wanted to talk a bit about assessing for orthostatic hypotension. So when you look at the medical literature, I actually didn't realize this because I was at Legacy for a number of years and now at the Portland VA, and our nursing staff has always checked orthostatics in 3 positions, so supine, sitting, and standing. But if you look at the medical literature, they actually recommend checking orthostatics just in 2 positions. So it should be supine for 5 minutes, and then standing, you check at 1 minute and then 3 minutes. I don't know how you guys check it here, but orthostatics are positive if you see a drop in systolic of greater than 20 or diastolic greater than 10, or in the presence of symptoms such as dizziness or lightheadedness. One of the things that we would ask you to consider is checking just a standing blood pressure. And we frequently do that in our geriatric clinic when our staff is pressed for time or we're pressed for time, because a standing blood pressure can actually give you a lot of information. So if their baseline systolic is not 90 to 100, then that's a concern already, especially if someone is falling or if they have symptoms. Treatment of orthostasis can reduce falls. So there is data to support medication reduction. That would be the first place to start. Also consider fluid optimization if that's an issue. Elastic stockings can be done, but they do need to be waist high. And a lot of our patients have issues with wearing a compression to that extent. Ankle pumps and isometrics, there is data for that. Consider adding salt. We've had several patients in our Falls Clinic where we've recommended salt, and they're just shocked. You know, they've been told their whole lives that they can't add salt to their diet, but if it isn't a contraindication, that is something to consider. And then in patients with more serious orthostasis, such as your Parkinson's plus patients, you may want to consider fludrocortisone or midodrine. So when it comes to diagnostics, we don't have any sort of gold standard in terms of tests, but it seems reasonable to send lab tests just to rule out things like anemia, dehydration, or vitamin D deficiency. The other tests would really depend on the patient's presentation as well as your history and physical. Okay, Ron?
So the good news is falls can be prevented, and because falls are multifactorial, oftentimes the prevention comes from a team. One of my favorite quotes in dealing with chronic illness or chronic conditions, aging is a chronic condition, is that a team approach is the most critical and the most valuable for those things. So from a physical, wrong button. From a physical standpoint, we can look at muscle weakness, and we're going to talk about exercises for those. Improved vision, cognitive retraining. From a behavioral standpoint, we just got done talking about the medications, especially those psychoactive meds. And from an environmental or occupational therapy standpoint, the clutter and the tripping hazards, poor lighting, and handrails. Again, we see the quote here for steady. We're going to talk about that at the end. It's a good thing Dr. Miura is here, because this would be my only slide and then we would be done. Exercise as a single intervention can prevent falls, and that's where physical therapy comes in. Incidence of hip fractures can be reduced through exercise. This is a great one when we're talking geriatrics. Low intensity strength training resulted in improved gait and stability. So it doesn't have to be anything real fancy or fantabulous, but strength and endurance training is critical. Here is a Cochrane review of a number of the top exercise interventions for falls. Pretty much across the board, all of them you see are effective for fall prevention. I brought in copies of the abstract for two of the strongest ones, Means in 05 and Suzuki in 04 are a couple of the strongest ones. So I have copies of those if you want. Means was a 6-week, where'd he go? Right there. 6-week physical therapy intervention, strength, balance, coordination exercise. Suzuki was a smaller study. It's a 6-month program. And the control group got standard care, right? Here's your handout, do these exercises at home. And the intervention group was 6 months of community as well as at-home training for better balance. Great results from those. Tai Chi is one of the interventions growing traction in Western medicine because it is super effective for falls as well as for cognition. Tai Chi improves posture as well as balance, decreased tug times, improves stride length. And this is kind of curious. I know that the data collection is probably different, but this was a paper done a couple years ago comparing incidence of falls in elders in Taiwan versus the United States. And Taiwanese elders fall down about half as often. So whether we want to blame the diet or the Tai Chi, I don't know, but it's an interesting little bit of information. And again, Cochrane has looked at Tai Chi interventions for balance. Really, there's a dearth of validated research on Tai Chi at this point, but the ones that they were able to pull up were generally shown to have a positive effect for reducing falls. This was just came out in February, the Journal of Safety Research, comparing cost-benefit of some fall prevention programs. So the Otago exercise program, anybody heard of that? Couple of them? Okay. So Otago is a home-based fall prevention strength and exercise program. 36% return on investment. Until we get over 80, then 127%. Pretty awesome. We just got done talking about Tai Chi. Here you go, bang for your buck. 509% return on investment for fall prevention. We talked about the $19 billion spent on falls and rehabilitation and caregiver burden and this and that. 509% return by doing Tai Chi. And Stepping On. Anybody heard of the Stepping On program? Providence should all be raising their hands. Stepping On is a Providence program. We're going to talk about that a little bit more. 64% return on investment. It's a good deal.
Or do you want to talk more about, because it's nowhere else.
It's not in there. I'm going to actually talk about it at the end when we have our steady slide. Home safety is one of the other things that we can cover to help prevent falls. Okay, having less clutter, no throw rugs, night lights, and handrails, very important. This is kind of an OT thing. I'm not an OT, but I can appreciate the effort that goes into evaluating someone's home and getting the environment that is comfortable for the patient but risky, seeing if we can reach some happy middle ground to help them to be more safe. Kind of a no-brainer. If we improve the safety of the walking environments where people walk, then they're not going to fall down as much. And we know that walking is critical as we age, maintains BMI, decreases risk factor for disease and dementia and mortality. So we talked about up to, depending on the paper that you read, 49% reduction in falls for Tai Chi. Strength and balance, I would have liked to see a little higher number there, but still better. Vitamin D supplementation, since we live in northern latitudes, that's kind of an important thing. Dr. Miura talked earlier about the medication, especially the psychotropic meds, and then a home safety assessment, actually 34% reduced falls. That was great. Some other modifiable things that we can consider, footwear and podiatry. There was a study that was done several years ago on falls risk with footwear. Socks or bare feet, like we all wear at home, highest risk for falls. Athletic shoes or sneakers were the best. In fact, a new study, new to us, new to this presentation, multifaceted podiatry intervention led to a 36% reduction in falls. Much like expedited surgery for cataract reduced falls. So the footwear eval and the vision screen, we do that in our geriatric assessment clinic, but referrals are pretty easy to be had as well. Yes? I don't recall the actual numbers, but one would think that wearing flip-flop sandals would be more dangerous than bare feet, yes, because you come half out of them and exactly.
What's a multifaceted podiatry intervention?
Well, so that, we go back. So I'm not a podiatrist either, right? But I am guessing that is an all-encompassing foot care thing where we're talking orthotics, we're talking proper well-fit shoes, we're talking nail maintenance, we're talking addressing issues like hammer toes and bunions and corns and plantar's warts, all of which can be painful and change a person's gait. So that's not just saying see the podiatrist, but that's actually doing all of the things that are critical for good balance and gait. That one's yours.
Okay. Thanks. So I wanted to say a word about vitamin D. I know this is the home of Mike McClung, and you've heard plenty about vitamin D, but we do have data to show that in those over the age of 65, low levels, so severely deficient ranges of less than 10, are a problem because these folks are at greater risk of muscle mass as well as strength and increased risk for hip fracture. The good thing about vitamin D is that there's a very low risk of harm in what we call appropriate doses. So in general, they say less than 4,000 units a day is safe. Dosing recommendations do vary depending on what society guidelines you look at. So the AGS recommends 1,000 units a day, and then some of the others recommend anywhere from 600 to 800 a day. And I think what's important in deciding a dose is that you look at the person's diet as well as other supplements that they may be taking. And a lot of times we go ahead and just check a level. We find that helpful in deciding the dose. So I wanted to say a few words about inpatient falls because they are so common. And how many here practice inpatient medicine? Okay, so several folks do. And what we find is that risk factors are similar to those in the community, so many of the ones that I already reviewed. But what we see are older age, again, the history of falls comes back, cognitive impairment, especially dementia and delirium, dizziness or vertigo, and then environmental hazards can be a problem in the institution, including wet floors, furniture, so cluttered rooms, improper toilet or bed height, and then floor type can also make a difference. So they find that people fall more on carpet than vinyl floors. Impaired mobility may be an issue in the hospital, especially someone that's post-op or acutely ill. Medications, and then visual impairment. So when it comes to screening tools, there are multiple ones. And what most folks use is the Morse scale. How many folks have heard of that, the Morse? So a few folks, yeah. So there are 6 items that you see listed here. The score ranges from 0 to 125, and this is typically done by the nursing staff. It's considered positive, so the person is high risk for falls if it's greater than 45. What tool do you use here? Do you guys know what? Oh, okay, the Henrik, yeah, okay, all right. I see, okay, all right. Yeah, at the Portland VA, we use the Morse, so. Now,
How long have you used the Morse?
you know, I've only been there for a little over 2 years, but I know they've used it definitely for several years, and at Legacy, they use the Morse too, yeah. So for interventions, the literature supports a multi-targeted interdisciplinary approach. So any of these in isolation aren't very effective. So they recommend balance and strength exercises, usually recommended by physical and occupational therapy, environmental modifications if needed. Education of staff can be very helpful, medication review on a regular basis. Toileting interventions can be very effective. What we found in our own hospital is that where our fall rates are actually very high, is that a lot of the falls were occurring around toileting, with people trying to get to the bathroom. So it does make a difference to think about scheduled toileting or a bedside commode. Footwear, non-skid footwear can be effective. So you've all seen the socks with the tread on one side, that when the person gets up, it's already turned to the dorsal surface of the foot, so is very slippery. Now they're recommending footwear with socks and the tread all the way around. And then a comprehensive geriatric review can also be helpful. Vitamin D, again, can be helpful even in the inpatient setting or nursing home setting. There's evidence for that. Now, there's no evidence to support the use of restraints or bed rails. So we know that they cause more problems in terms of pressure ulcers, contractures, and even severe injury. There is some data on bed or chair alarms. We use them quite a bit in the hospital and in the nursing home settings. They tend to be annoying to folks just because there's a lot of false positive signals. But again, when it comes to this sort of multi-targeted approach, there is data to support their use. Okay, so I'm going to move into our Portland VA fall assessment clinic and how we break things down. So we're fortunate that we have not only house staff, so we have trainees in internal medicine, but also geriatric fellows. And we're very lucky to have Ron, our physical therapist, with us too. So how it works is a patient comes in, we have an LPN who rooms the patient, automatically does orthostatics and a vision check. And we also give every patient what we call a pre-visit form. So it has a questionnaire about fear of falling, as well as other like review systems and other lists for them to fill out. Then as a team, we perform the history and physical. Ron does a functional assessment, and I'll talk about the tests that he does. Medication review is something that the physician does. We do an environmental review, and then we screen for a cognitive impairment with the mini-cog that I talked about earlier. And then together we decide on recommendations and a plan. And what we found has been very helpful is an action plan. So we do a buy-in session with the patient where we have them identify what they're going to do before they see us again. So we usually, that's some sort of exercise or balanced program or Tai Chi is very common. So just in summary, for a falls evaluation in our clinic, we check orthostatics and vision. We do the mini-cog. We review medications. We assess fear of falling with the FESI, so the Fall Efficacy Scale International. I don't know if anyone's used that here. But the nice thing about it, it's just a questionnaire with 7 questions total, and then you add up a score, and it's positive if it's greater than 20. So again, fear of falling being a significant risk factor for falls. And then Ron will perform the gait and balance assessments that you see here. And time-wise, in especially a primary care clinic, it would be wise to do a few of these since they can be time-consuming. But what we would recommend is the timed up and go and gait speed. So together, those should take about 5 minutes or less. And we gave you the data behind those. And then the last thing we do is we give our patients a home safety checklist. So we're going to do a quick case study. So this was a patient we saw in our clinic, 80-year-old male with 4 falls in the past month, history of hypertension, osteoarthritis of the knees, depression, and CHF. He was on more medications than this, but his 2 key meds were lisinopril and amitriptyline. And on exam, he had arthritis of his knees, trace ankle edema, positive orthostatics, and he had problems arising from a chair and needed to use his arms. His gait was slow and wide-based, and his tug was positive at 25 seconds. And the mini-cog was abnormal. So a bunch of positives there. So this is your last clicker question. What is the best intervention for Mr. G? Oops. A, assume his abnormal mini-cog is due to age. B, add furosemide. C, consider reducing his medications. D, check a vitamin D level. Or E, continue his current regimen. Okay. Wait for a few more. Wow. Okay. Okay, good job, you guys. You were listening. Okay. Okay. Let me hide this. So that is correct. So C, consider reducing his medications. So for this person, the first thing we did was medication modification, so addressing his orthostatic hypotension by decreasing his ACE inhibitor. We also ended up tapering down his TCA. We scheduled acetaminophen for pain and added vitamin D. We checked a vision screen on him, which actually did end up being positive, and we recommended further cognitive testing because of the abnormal mini-cog. We referred him to a fall prevention class called Stepping On, and Ron will tell you more about that. We gave him the home safety handout and did the action plan, that patient buy-in session for exercises. And then we've been fortunate in that we were able to make our own fall prevention DVD at the VA. So if you have any veterans out in the community, we do at our Falls Clinic have that as one of the carrots to bring them in is that we give them, or we offer a DVD that we actually made, and this was to address those logistical barriers to accessing exercise programs or Tai Chi. So we actually have our own Tai Chi segment in the video that's about 13 minutes long, and then Ron does a section on PT exercises, and then we have an occupational therapist that actually walks a veteran through a home setting and how to perform a home safety eval. So, Marianne?
Yes, I have a question. How
Sure.
do you assess the footwear in your falls prevention clinic? Do you have them bring in all of their shoes in a big brown bag and go through them? How do you do that?
We don't. Yeah, I wish we could be that thorough, honestly. It's the shoes that they're wearing when they come in. Yeah.
It's probably not the slippers they wear.
Probably not, no, but we try to, as part of the home safety, emphasize that.
Actually, one of the parts of the Stepping On program that we're going to cover next, one of the classes in that is Bring In Your Shoes. And they cover that in Stepping On.
This one, yeah.
How much of what you do in the fall clinic do you incorporate at time of discharge for inpatients? Or do you refer them to the fall assessment clinic at discharge?
Right, so we encourage that inpatient that they be referred to our fall assessment clinic. So right now there isn't anything that is organized that way inpatient-wise. So I'm part of the falls work group inpatient, and we're trying to develop those things. But yeah, it's a great idea. So, okay. So in summary, today we reviewed the evidence when it comes to the assessment and management of falls. So remember to inquire about falls annually and to try to identify folks that are high risk and intervene. When it comes to interventions, there's a lot of evidence behind exercise, especially Tai Chi, doing a medication review and adjusting if necessary, especially looking for psychotropics, and then treating underlying contributing factors like vision, cardiac, orthostatic hypotension, cognitive issues, and low vitamin D. So those are the modifiable risk factors. And then the last thing is to think about an environmental assessment and modification, whether that's a home safety list that you give them or a referral for a home health OT assessment. And Ron will finish up.
Okay, so a couple of times we've talked about STEADY, which stands for Stopping Elderly Accidents, Deaths, and Injuries. STEADY is a CDC toolbox, and there's a link at the bottom if you just remember cdc.gov, home and recreational safety. So it's a toolbox that has things like that 4-stage balance test, which includes the Romberg and the single limb stance. It has data and validated studies in there. It has that falls can be prevented screen with all of the multidisciplinary things. It has gait and balance tests and instructions and videos, so you can see what would incorporate into your clinic as well as a list of medications that are might be related to falls, kind of thing. Educational handouts, not only for the providers, but also for patients. So the STEADY toolkit is fabulous. Now, STEADY is part of the CDC's Compendium for Fall Prevention, which is a nice size little book here that you can download the PDF for. But basically, it has dozens of fall prevention interventions, including things like Tai Chi, 509% return on investment, the Otago home exercise program that we talked about, Stepping On, which is a once-a-week, 7-week group fall prevention and exercise class. Out of those 7 weeks, 3 of those weeks have a physical therapist come in to do exercise. There's a pharmacy week, there's a Bring In Your Shoes week, there's a vision and a community safety week. So Stepping On, as well as a lot of other things. I just listed, a dozen here out of the probably 50 different fall interventions in the CDC's compendium for fall prevention. So I have a copy of that if you guys want to see that. Questions from the floor for both or either of us?
Thanks.
Is Medicare paying for those Stepping On classes?
Currently, I think the answer would be yes, because Oregon is one of 3 states piloting Stepping On through 2016.
Can I actually address that?
Totally.
So for Providence, if you're in the If you're not in the Providence Health Plan, I think it costs you $35 for the 7 classes if you go to one of our Providence classes.
And is that just ordered through the physical therapy?
Yes.
Board? Okay.
Yeah, and that's for all 7 classes, so it's a great deal.
Yeah.
Thank
wow,
you.
25. That's good. Any other questions?
No more clickers.
All right.
Just questions.
Thanks, you guys. Okay. Thanks for having us. Okay. Nice job.